The No Surprises Act is here. During this AMA Advocacy Insights presentation moderated by Dr. Bobby Mukkamala, chair of the AMA Board of Trustees, experts discuss the implementation of the No Surprises Act. Speakers walk us through enforcement challenges and the interaction between state and federal surprise billing requirements. Here's Dr. Bobby Mukkamala.
I'm Dr. Bobby Mukkamala. I'm an otolaryngologist here in Flint, Michigan, and it's my honor to serve you as chair of the board of the American Medical Association. Reducing the burden of unanticipated medical bills for patients through changes in federal policy has been a priority of the AMA for many years. The AMA strongly supports protecting patients from unanticipated medical bills that can significantly raise out-of-pocket expenses and threaten access to quality care. And we supported these reforms as part of the No Surprises Act. That said, the implementation of the No Surprises Act is going to be incredibly challenging for physicians and other providers, and we are already seeing challenges arise since the law took effect on January 1st. As we will hear today, this new law brings a number of changes that are important to understand because they have the potential to significantly impact physician practices, including a ban on out-of-network billing in several situations, changes to disclosure, as well as notice and consent rules, and new price transparency requirements. And there are many questions as well, such as how existing state surprise billing laws are interacting with this new federal law, and who is enforcing these requirements at the state level. Will not focus heavily on the independent dispute resolution or IDR process available to physicians to challenge plans out-of-network payments, given the pressing nature of these other NSA requirements and the fact that some of that IDR process is still being finalized in many ways by the current administration. Please be on the lookout for more programming and resources on that part of the law, the IDR, in the near future. However, I will mention the AMA's ongoing concern with the way in which the Biden administration is implementing the IDR portion of the new law and the actions we have undertaken to hopefully make that process more balanced. As many of you are aware, regulations implementing the IDR process place a thumb on the scale in favor of insurers by requiring the arbiters to consider the health plan's median in-network rate as the appropriate out-of-network rate in most situations, and essentially predetermining the outcome of the process. Last month, the AMA joined with the American Hospital Association in suing the federal government for stepping outside their statutory authority in implementing the independent dispute resolution process under the No Surprises Act, and for upending the careful compromise Congress deliberately chose for resolving billing disputes. To be clear, the lawsuit doesn't challenge any of the patient protections in the bill or any of the new requirements on providers. Instead, it focuses on compelling the administration to bring the regulations in line with the way the law was written in Congress and allow the arbiter in the dispute resolution process to consider all factors relevant to payment that are enumerated in the statute. This will lead to what Congress intended: a fairer, more meaningful process to resolve disputes between healthcare providers and health plans. This challenge is a priority for the AMA, and I know a priority for many of you. We will, of course, be keeping you updated on that effort. But for the focus of today's presentation, we are lucky to have with us today two experts who were involved in the development of the AMA's surprise billing toolkit and who know a great deal about both the No Surprises Act and state and federal enforcement of healthcare laws. First up, we have Michael Kolber. Michael is a partner at Manatt with expertise in the implementation of health coverage issues, especially the Affordable Care Act, Medicare and Medicaid managed care, value-based purchasing, and employment benefits. He provides legal and policy advice with a particular focus on mental health parity, medical loss ratio reporting, pharmacy benefit management, risk adjustment, and healthcare non-discrimination rules. He also provides regulatory advice and advocacy, counsels clients on corporate transactions, and litigates in federal court and before administrative tribunals. Prior to joining Manatt, Michael was the lead legal advisor to the U.S. Department of Health and Human Services on several key features of the Affordable Care Act, including essential health benefits, health insurance exchanges, and risk adjustment. Also with us is Joel Ario. Joel has over 30 years of experience shaping and implementing public health policy at the state and federal levels and provides strategic consulting and analysis on healthcare policies and institutions, with an emphasis on the role of health insurers in delivering public and commercial coverage under various regulatory frameworks. Joel's experience includes 2 decades leading health insurance reform efforts for state and federal governments. As director of the Office of Health Insurance Exchanges at HHS, he worked closely with states and other stakeholders to develop the regulatory framework for exchanges, including the rights and responsibilities of states and the federal government in expanding coverage. On the state level, Joel has served as Pennsylvania Insurance Commissioner and Oregon Insurance Commissioner. He served on the executive committee of the National Association of Insurance Commissioners and was on the NAIC and was an NAIC officer. Joel also serves as an advisor to the Robert Wood Johnson Foundation in support of its work with states. As you can tell, we are in great hands to talk more about the implementation of the No Surprises Act. I will now turn it over to these experts for their presentation. Joel and Michael.
Thank you. So Joel and I are very happy to be here with you today. So I'm going to talk through some of the sort of the basics, the blocking and tackling about what's in the law, what's in the regulations, and what you as physicians need to know now about implementing the law. And hopefully you and your practices are beginning to, since it has been in effect since January 1st. And then Joel's going to talk a little bit more about just the really complicated network of state and federal regulators and enforcement that will be overseeing all of this and how those are interacting, frankly, in one of the more complicated ways Joel and I think have seen. So the basic issue in the No Surprises Act, and it's many components to the statute, some of which may have very little to do with surprise medical billing, but the core protection that we're most focused on is the prohibition on surprise medical billing, really in just 3 circumstances. For emergencies, for emergency services that are rendered in hospital EDs or freestanding independent EDs, out-of-network air ambulances, and certain non-emergency services provided by out-of-network providers at an in-network hospital or ambulatory surgery center. And hospital, I'm using a shorthand for hospital, critical access hospital, or a hospital outpatient department. And in order to implement these and related provisions, there are really 4 things that we think that physicians need to know now, most of which are covered, as mentioned, in the AMA toolkit that we worked on. The first is, how is patient cost sharing and provider payment determined for these out-of-network situations? 2, what obligations exist to provide good faith estimates to patients? The good faith estimates that we're talking about here actually don't tend to relate to the surprise medical bills because currently this is only being forced for uninsured or self-pay patients, whereas the surprise medical billing situations only arise for insured patients. But it is a really substantial implementation challenge that providers are dealing with today. So we want to spend some time focusing on that. Third, when an out-of-network provider treats a patient at an in-network facility, whether a hospital or an ASC, when can they get consent to balance bill for those non-emergency services, essentially when a patient has voluntarily chosen to get treated by an out-of-network provider? And 4, when can the provider or the facility get consent to balance bill for post-stabilization services in connection with an emergency visit to a hospital or a freestanding ED? This was sort of a unique feature, a somewhat unique feature of the No Surprises Act, that among the emergency services protections, it includes post-stabilization services and not just assessment and stabilization of emergency patients. And so the question about when can a provider bill at out-of-network rates for post-stabilization services becomes newly important. And underlining all of these is how do the existing state surprise billing laws interact with the federal laws, and who is going to be responsible for enforcing them, which, as we've said, gets pretty complicated, and we'll walk through a few cases to explain it. First, and this is sort of the overarching process for surprise medical billing. First, we're principally talking about two situations for the most part. I'm not going to talk about the air ambulance situation. So the two situations we're most concerned about is if a patient is seen as at an out-of-network ED, including freestanding ED, or there's a charge for an out-of-network ancillary service received in an in-network facility. These are, tend to be out-of-network services for which the patient couldn't have consented in advance to receive treatment by an out-of-network provider, anesthesiologist, radiologist, labs, hospitalist, and the like. So in either of those two situations, one of the core protections is that the patient can only be required to pay the in-network cost sharing under the patient's health plan. And all of these, the context is this is an insured patient that either has employer-sponsored coverage or has individual market commercial coverage. And so a patient would be limited to only being required to pay the in-network cost sharing. Of course, if that's a co-payment, it's straightforward to know what that amount is. If there's a deductible or co-insurance, increasingly common, then a determination needs to be made about how that in-network deductible or co-insurance is calculated. And that's based on what's called the recognized amount, which essentially is one of these three things. It's either the amount that would come from a state all-payer model agreement, that's only Maryland, whether there's a state law outside of Maryland that determines what the patient cost sharing should be. And if there is a state law that applies to a particular service by a particular provider under a plan, then that would apply. Or the qualifying payment amount, which is essentially the median in-network rate. So essentially the plan will be required to determine which of these three rates applies, if it is the QPA, calculating the QPA, and then reporting back to the provider what the cost sharing should be based on that analysis. The plan then either denies coverage or makes a payment, which is supposed to be a sort of a reasonable payment amount. And there's a period of potential negotiation if the provider disagrees with the plan payment. If there isn't agreement in the negotiation, the payment goes to the IDR process that you heard briefly about before I got on. I think one thing to highlight here is that there's two separate calculations. One for the patient cost sharing, which happens at the front of this process, and two for the out-of-network reimbursement, which happens at the end of the process. So patient cost sharing should be able to be determined, relatively quickly, and the patient's obligations should be resolved relatively soon in this process. Even if there continues to be a dispute between the provider and the plan about what the out-of-network reimbursement should be to the provider. And the result of that, dispute, if it does go to arbitration, does not affect the amount that the patient ultimately pays. It's just between the plan and provider. So that's one of the core protections, is taking the patient out of that dispute. I'll mention briefly, as you heard, there is litigation about the IDR process and the rules under the IDR process in terms of what the arbitrator should consider when determining what the out-of-network reimbursement should be. There have been several cases filed about this. We should, I think, expect, we may begin to see some decisions from the various courts. And, depending on the outcomes of those cases, they may be appealed. So through the spring, we may begin to get some insight into, what the outcomes of those litigations may be, which would sort of time nicely with when these IDR arbitrations will begin to occur. We don't have all the steps in here, but generally the IDRs could not begin until 90 days after a service was rendered. So since this first started applying in January 1st, it may be that in April at the earliest, there may begin to be some arbitrations.
Medicine doesn't stand still, and at the AMA, neither do we. AMA members are physicians like you who are shaping the future of medicine. Become a member today and join the movement. Visit ama-assn.org/movingmedicine.
So I want to go into a little bit more detail about the recognized amount, and this is the amount that the cost sharing is based on. And these are calculations that are going to be done by the plan and then reported to the provider about how much should be collected. Essentially, it should result in an amount that's no more than would have been charged if an in-network provider had provided the care. As I mentioned, there's these three standards, essentially the Maryland model, a state law if it applies, or this QPA, which as I indicated previously is generally the median contracted rate. It's actually the median contracted rate from 2019 that is then inflated forward, and then there are special rules when the median contracted rate doesn't apply, such as like the plan was created newer than 2019, or the service didn't exist in 2019, so there isn't a contracted rate for it. There's special rules that apply. Worth noting that for ERISA plans, private employer self-insured plans that don't use health insurers to underwrite their costs, generally the federal rule is going to apply about what cost sharing should apply. And then, as I said, there's this separate calculation of the out-of-network rate, and that amount, again, is going to be, either the Maryland all-payer rate-setting model, if there's a specified state law that determines it, and then the federal IDR process. I talked about the federal IDR process. Just a moment more about the specified state law, because I think in many states that may determine the reimbursement, because a significant number of states already had state surprise billing laws before the No Surprises Act was enacted. And in general, in order to be a so-called specified state law, the law needs to determine the reimbursement amount for the particular service rendered by the provider type at issue and for the plan at issue. So, for example, a state law might regulate reimbursement for example, emergency services, but not non-emergency services. A state law might regulate particular out-of-network providers. It might go by particular specialty types that it regulates and not other specialty types. So it's conceivable, and in fact, it's likely that even in states that have state laws that set out-of-network reimbursement amounts, there will be certain types of plans, certain types of providers, certain types of claims that out-of-network reimbursement might still be determined under the federal methodology, even if the state methodology does apply to some cases. And we are seeing some states, considering expanding the scope of their state laws to the extent they can, so that there's less of a Swiss cheese jigsaw puzzle, and the state law applies more broadly. So the good faith estimate has been an area of sort of enormous agita among providers, because it's sort of one of the first things that really needs to be implemented by providers. I think the first thing worth noting about the good faith estimate as it's currently being applied so first off, the good faith estimate is a requirement to provide patients a good faith estimate of the charges that are expected, either upon request before a scheduled service is scheduled, or at the time that the service is scheduled and before it's rendered. There have been two significant relaxations of this requirement under the federal rules and guidance. First, currently it's only being enforced with respect to uninsured or self-pay patients. These are patients that don't have any form of health coverage or have commercial health coverage, and they're deciding not to use that health coverage. If patients have Medicare or Medicaid, this requirement doesn't apply at all. The second relaxation that I think is significant is the good faith estimate, at least for this year, is only required to include the expected charges from the provider who's actually providing the estimate. Supposedly beginning next year, the departments are going to enforce a requirement that it includes the expected charges of other providers and other facilities that may be involved in the service, other than the one that's scheduling the service. So, if a hospital is responsible for scheduling service, then the treating provider's charges should also be included. So, that requirement for the other providers to be included supposedly is going to go into effect January 1, 2023. And then, as I mentioned, it's only being enforced for self-pay or uninsured patients. It will supposedly eventually be applied to insured patients as well. That is going to be even more complicated because the plan is that these good faith estimates would not necessarily be provided directly to the patient, but would be provided to their health plan, which would then use that good faith estimate to generate what's being called an advanced explanation of benefits, which would tell the patient how much out of pocket they would have to pay, essentially like the explanation of benefits they would get after the services are rendered. But obviously there's a lot of interconnections that will be required between providers and plans that don't currently exist and will need to be put in place somehow before that requirement is enforced to provide GFEs to insured patients. So that does not currently exist. So there's a number of regulatory requirements about what needs to be in the good faith estimate. It's principally a description of the services that are expected to be provided and a listing of the charges that are expected. There is a template form that the federal government has produced that sort of lays out how all this information should be included in the good faith estimate. There are a number of other sort of notice and other requirements that are associated with this good faith estimate requirement. First off, there needs to be a notice provided that explains the availability of the good faith estimate. It has to be posted on the provider or facility's website, at the office, and wherever scheduling or cost questions arise. It has to be clear, understandable, prominently displayed, easily searchable. There's also a template for this notice. And then when does it need to be provided? As I said, it has to be provided when a scheduled service is scheduled, but it can also be provided it must also be provided when requested by a patient, even before they've scheduled the service. The rules have a pretty broad definition of when a GFE has been requested. Essentially, any time a patient asks about cost, that should be interpreted as a request for a good faith estimate that complies with these requirements. And then one of the really sort of significant consequences of the good faith estimate for uninsured and self-pay patients is that if the actual charges for the episode of care described in the good faith estimate exceed the good faith estimate by more than $400, the patient can dispute that bill through a new patient-provider dispute resolution process. This is separate from the IDR, independent dispute resolution process, that exists in the context of surprise medical bills. Essentially, if any particular provider or facility's charges exceed, their estimate by $400, this process can be triggered. And once it's triggered, the provider has to provide evidence to this new dispute resolution entity. Essentially, the only reason that they can defend the higher than expected charges is if the higher charges were because of medically necessary items or services that could not have been reasonably anticipated when the good faith estimate was provided. I think providers are thinking through a number of ways, to avoid having to participate in this dispute resolution process. One might want to give good faith estimates that sort of err on the side of going high. That, of course, presents problems because it may deter patients from getting medically necessary care if the estimate is sort of artificially too high to avoid these dispute resolutions. Another thing that providers and facilities might do is look at their bills before they go out and see if they can be essentially ridden down on the front end so that they don't exceed this $400 threshold. And then there may be some thoughts of sort of going through the process for at least some claims and seeing how it turns out. But it seems like there's going to be a significant operational burden here to go through this process. So discussing sort of two of these sort of core issues in surprise medical bills. And in generally, this applies to the two situations we're talking about where there really are protections against surprise medical billings. First, the situation of non-emergency services in an in-network hospital or ASC, and the other is emergency services at a hospital or independent ED. And in both of those cases, despite there being this new federal protection against surprise medical billing, there are situations when a provider could bill at their out-of-network rates and potentially balance bill. For non-emergency services, if it's a service that can be, actually selected by the patient and the patient actively wants to use that out-of-network provider, The provider can provide notice of the balance billing ahead of time. It has to include an estimate of the charges, and then the patient can consent to be balance billed. Now, this is for any provider type, except for ones that are specifically prohibited from balance billing under the regulations, which are, things like, again, emergency medicine, anesthesiology, pathology, radiology, neonatology, sometimes, referred to either as ancillary services or services that a patient can't reasonably, select a provider, hospitalist, intensivist. And then in addition to all of those, there's sort of a catch-all for any sort of urgently needed care that arises that the patient doesn't have a reasonable opportunity to select a provider for. But, say a patient wants to be treated by a particular surgeon who's out of network, but they want to do it at an in-network hospital, for a scheduled procedure, the patient is permitted to do that and, consent to pay the full out-of-network charges. If that's what they choose to do. There are some timing requirements about, sort of when they need to consent to be balance billed prior to the procedure. And then for ED visits, as I said, this statute was somewhat unique in describing post-stabilization care as part of these ED protections. Despite saying that post-stabilization care is generally part of an emergency visit and subject to these balance billing protections, there are circumstances in which a provider or facility can seek to obtain consent to balance bill. It has to be for care that the provider determines the patient could travel to a network provider using non-emergency medical transportation or non-medical transportation, meaning taking a cab or getting on a bus and going to a different hospital. And if that is true, and if the patient is in a physical condition in which he or she can actually consent, then the patient is provided notice, an estimate of what the out-of-network fees would be if the patient stayed at their current out-of-network facility, and the patient consents. You would all know better than I, but I suspect this is a somewhat unusual circumstance when this would ever occur, when a patient essentially can't be discharged, or there's medically necessary care that the provider thinks still needs to happen in the hospital, and yet the patient is well enough that the patient could travel by non-emergency medical transportation and get the care at an in-network provider. Maybe if there's an in-network provider like in the same building or something like that, it may be a situation where that could arise, but otherwise it may be a sort of rare situation when there really is even an opportunity to get that consent to balance bill. And so just to mention, as we said at the top, that we did prepare with the AMA this toolkit that goes into somewhat greater detail on I think all the points I've raised today, and so we hope you take a look at that. And I think the link is available both here and by email. With that, I'll turn it over to Joel.
Thank you, Michael. So the states vary a lot, and then the states also have choice under this law as to whether they want to enforce their own laws or defer to federal enforcement. So you're going to end up with a patchwork, not only among the states, but also within the states with regard to different sorts of services. The basic standard that applies here is that, again, the states get to choose if they want to enforce the law, but if they don't choose to enforce it, or if they choose to and then don't actually enforce it, the federal government does have authority wherever the state is not, quote, substantially enforcing the law. There's a third of the states don't have any kind of balance billing or surprise billing type law. A third of the states have a law, but it's a partial law, and then a third of the states have something approaching a comprehensive law in covering these sorts of issues. Those of you who are familiar with the ACA will recognize that standard as the ACA standard of deference to the states, but ultimately federal authority behind that. There are two ways that a state can choose to be the primary enforcement agent. One is that they have a law in point and they choose to enforce that law. Again, that can vary by circumstance, but that would be one way the state can enforce the law. The second way is a collaborative enforcement agreement. I'm going to use the acronym here a little bit, CEA, but the collaborative enforcement agreement is a mechanism in this law where the state contracts with the federal government to essentially be the federal government's agent in enforcing the law. It works as long as the parties comply with what the state does as the agent of the federal government. Ultimately, the federal government would have to step in under a CEA arrangement if there were, disputes and parties were not complying with what the state thought was the right solution. So it's an attempt to give the states power, but it doesn't ultimately work if there's not voluntary compliance. If it's an insurer issue, most likely the insurance departments, well, in every state, the insurance departments are going to have authority over fully insured plans. That's roughly half of the employer-based market. The states do not have authority over self-insured plans here as in other areas. There is a little quirk here, which is that the law does allow employers to choose state enforcement. So a self-insured plan, a large employer could elect to be subject to state enforcement, but they don't have to make that election. And the state doesn't have to allow it either. Provider enforcement is, unfortunately for you guys, a little bit more murky at the current point. The departments of insurance could have been given authority under those state laws that predated this law or under the federal law for enforcement here, but they haven't been generally given that authority, and most of them are reticent to exercise that sort of authority through a cooperative agreement or some other mechanism. So in general, provider enforcement has been, in most of the situations to date, handled by delegating it back to or deferring to the federal government. There are, in some cases, we'll see as we get through here, health departments, licensing boards, consumer protection agencies at the state level who may have some authority on the provider issues. And then as Michael went through all those different circumstances, the way to think about enforcement is in each of those different circumstances, the state could make a different choice. So they could choose to enforce in emergency rooms, but not in, the situation of an in-network with an on-network provider, et cetera, et cetera. They could choose to enforce against insurers, but not providers, et cetera, et cetera. Something that may start happening more in the states that already is in one of the examples I'll talk about. States could try to help consumers, complaint handling, that sort of thing, can help them navigate the process. And that might include working both with state and federal agencies. And then, of course, on most of the new provisions, the states are going to probably defer these GFEs, particularly to federal enforcement, till things get sorted out a little bit. Washington was the first state to kind of jump out of the box and assert what it was going to do at the state level. Washington's one of these states with a pretty comprehensive law. What Washington said in a bulletin, I think it was early November, that they would enforce many of the provisions of their, basic, pretty comprehensive surprise billing law. So the billing protections against balance billing, the calculation of enrollee cost sharing, the provider payment and dispute resolution processes, all of that would allow Washington to essentially use its state law to enforce the whole process. But what they said was that if they got to issues with air ambulances, they didn't have authority there. So the state defer that back to CMS. Self-funded groups, Washington did take advantage of the notion that employer groups could elect to be put under the Washington law. So they will enforce the law for if there's that election, but otherwise they delegate it back to the federal government. And then for health providers, they basically said, not our area have been given authority. So they're going to delegate that but to the State Department of Health. It's unclear what the State Department of Health is going to do in Washington still. And for facilities where there really wasn't in Washington authority over providers, that would go back to CMS. And then you see this detail about provider directories. There's a bunch of other things in the law where the state might have a law. Washington has what it thinks it has a better provider directory law than what's in the No Surprises Act, so they've taken enforcement there as well. But you see already that it gets pretty complicated pretty quickly with the states. And again, I wouldn't rely on anything that you're hearing today as a done deal. It will probably evolve over time.
You took care of the nation. It's time for the nation to take care of you. The AMA stood by America's physicians and patients during the pandemic, and we're not stopping there. We're fixing prior authorization, leading the charge on Medicare payment reform, supporting telehealth, fighting scope creep, and reducing physician burnout. It's time to rebuild, and the AMA is ready. To learn more about the AMA Recovery Plan for America's Physicians, go to ama-assn.org/time to rebuild.
this is kind of the big picture of how this is going to evolve. I mean, again, Washington is one of the few states, there are a few more, Delaware is another example, that have put out things at the state level so far saying what they intend to do. But most of the activity so far has been private channels with the CMS, with the federal government, talking to people in the states, oftentimes the insurance regulators, but could be other state officials as well. And then through that process, they develop an understanding between the parties as to how enforcement will go. Many of us hope that what we'd see how that process was a kind of nice big chart that put everything together at a high level so we could just kind of skim through and see what every state is doing. But the way it's actually working is that CMS produces letters, pretty boilerplated letters, about 6 pages long, that go through the detail of what the arrangement is in each state. They've done that for 41 states so far. So they're a bit difficult to read, but they do tell you, if you understand how to read them, what the state will enforce directly, what the state will enforce through a collaborative agreement, and what CMS will enforce in quite a bit of detail. The collaborative agreements in these letters so far are an intention into the future. So to my knowledge, none have been produced yet. If I had to bet, Pennsylvania probably has the first of these because they've been more aggressive about trying to get a collaborative agreement, but that's still something that's coming in the future as well. So that's kind of what we know so far. Again, none of this is going to be written in stone yet, but it gives you an example, kind of a flavor of what states are thinking about so far with state versus federal enforcement. So you have Texas, which very proud of their law. Their laws work pretty well by all accounts down there in Texas, or maybe not all accounts, but in general, it's getting high marks. And it does address the broad range of issues, balance billing, dispute resolution. In Texas, they have told the federal government they like their system. It's got a lot of voluntary compliance on all sides. And so they want to keep the Texas Medical Board, the Texas Board of Nursing doing provider enforcement issues. They want to have the Texas Health and Human Service Commission regulate the healthcare facilities. And then, of course, the insurance department regulates the health plans. So if you want an example of a pretty robust state enforcement, states stepping up and saying, we're going to do it all, Texas is a good example of that. Cooperative agreement, Pennsylvania, they had a partial law in place. So there, the Pennsylvania Insurance Department has been working with the federal government to coordinate state and federal enforcement. Part of that is if you go up on the insurance department's website, you'd see a web-based complaint handling system there where any consumer who can't figure out where to go with the federal or state government on some complaint, they can go to the PID website, enter a few basic pieces of data, and then they'll get complaint handling help to walk them through their complaint, which again will in most cases probably include both state and federal enforcement agencies. In the state, that includes the Department of Health. That's going to crop up in every state where this is moving beyond the insurance department. The state Department of State, actually in Pennsylvania, has provider licensing responsibilities, and the Drug and Alcohol Program has some provider oversight responsibilities as well. And then, of course, they are coordinating with the federal government in certain areas like providers and facilities, self-funded plans. The Federal Employee Health Benefit Plan, not a small thing. There are a lot of federal employees. It's another area where there needs to be coordination. And then finally, there are going to be some states who want to just basically hand it over to the federal government. And the example here is Alabama, which has said, they don't have any law under no specific surprise billing law. And they also, even if they did, not indicated any interest in enforcing. And so in that case, the federal government enforces. I do note there that Colorado could decide in the future, these decisions are revocable. So Alabama could pick up enforcement at some point. And by the way, this could include, we don't know, I haven't seen a good example yet, but there are some states on the map with specified laws and comprehensive schemes that some people think may decide not to enforce those schemes, may decide simply to hand it over to the federal government. So even if you have a specified law, it doesn't mean for sure you're going to enforce. You still have the choice. The future of federal and state enforcement, this is a little bit of crystal balling, but I think at this point, states are generally deferring to federal enforcement for providers in their initial planning. That's particularly the case when I talk to states that, they don't want to be in a situation where they might want to be in a situation where they send a notice to providers saying, this is what we think the right solution is. But if the provider says, I disagree, you're going to have to enforce that. I so far know of no state that says they want to get into, an enforcement fight like that. That would get delegated back to the federal government for now. But the process could change as the rules get clarified. We've already talked about the fact that the rules, and I think a lot of it ultimately where this ends up being federal versus state will depend on the preferences, frankly, of your group and some of the other stakeholders. On one end of where it could end up is like ERISA preemption, where the states have been basically preempted from regulating self-insured plans since the 1970s. Even where states have wanted to regulate here, and some states have tried pretty hard, they basically get pushed back and not allowed to do it because the employer groups really oppose it and they zealously guard their exemption. So you could have a situation where some party or another is trying to make sure that states really don't have much of a role here. On the other side of the equation, the ACA enforcement process, started out with, the federal government having a lot of new rules for the states and many of the states wanting to resist those rules. But as of today, 48 states do their own rate reviews. Again, they have to go get certified by the federal government. They have to follow federal rules. But 48 states, Texas being the most recent, do their own rate reviews. 21 states, so less than half, still do state exchanges. The others for the federal government. So you see a general pattern there of, the stakeholders generally preferring state regulation, CMS generally deferring to that. And so it moves towards state regulation. But not entirely. One challenge in this area as this moves forward is that there is no natural home at the state level for provider enforcement. There just aren't issues on which there's a process in place to enforce things like this. There aren't laws like this for providers. So that's a hurdle. It could end up being insurance departments. I think the NAIC's put out something about provider responsibilities under the law bulletin. So, they understand how the laws work in this area. They could do more, but so far that hasn't really been invited by any of the parties. And so it's kind of sort of operating in the background more. What's coming up, implementation of the law, as Michael mentioned, by the clock, it can't be any, there won't be any independent dispute resolutions until at least April. We'll definitely see more guidance and more regulation from the federal government. Some issues are going to get resolved through litigation, as we've discussed. I do think you'll see a lot more action at the state level, at least on the consumer protection side, and maybe on the enforcement side. And there are some additional resources in the deck that sort of foreshadow some of where that could go. And then there'll be efforts to coordinate and harmonize. You see that these small differences between state and federal law create a lot of difficult kind of decision making and handoffs and so forth. You're starting to hear some states talk about maybe we'll just pass laws that make us have the exact same provisions as the federal government, at least in certain areas, just so the laws are harmonized. So there may be more of that activity as well. With that, I'll turn it back over to Dr. Mukkamala.
Yes, thank you so much, Joel and Mike, for offering this important and timely information on the No Surprises Act. And also, please be on the lookout for additional AMA content on the No Surprises Act, including, again, this IDR process. Thank you for joining us. Enjoy the rest of your day.
You can subscribe to Moving Medicine and other great AMA podcasts anywhere you listen to yours, or visit ama-assn.org/podcasts. Thanks for listening.